I think the most important advances have been the introduction of new drugs that are not cytotoxic agents. Historically, we've always just used cytarabine, anthracycline, drugs that are cytotoxic. Now we're increasingly having drugs that have specific mechanisms of action directed at certain molecular abnormalities, directed at FLT3, directed at IDH mutations, or antibody drug conjugates, BCL inhibitors, hedgehog inhibitors, so much more selective therapies that are making us have better outcomes and increased safety for our patients. Well, there's two main categories of adverse events. One is the non-hematologic adverse events. And the problem that we've had with cytotoxic agents is that they're toxic to the body. They can have damage to the heart and damage to the kidneys and the liver and all of that. And that makes it very difficult for many patients to even tolerate that, increases the risk of mortality during induction and limits how much you can give the therapy. Then there's also the myelosuppression, which is a more common feature. It's part of that is related to the disease itself. Part of that is the treatments, particularly when you do it with cytotoxic agents. And the problem with that is that patients have comorbidities. Many of the patients are older. So it makes it very difficult to manage our patients. And again, that has limited our endpoints, our ability to improve the outcomes of the patients, and limits patients that can have the therapy that we had available. The IDH1 gene is mutated in about 8 to 12%, 15% of patients with acute myeloid leukemia. And it is important because we know that when that gene is mutated, it changes the metabolism in the cells in such a way that there's part of the respiratory system of the cells, the alpha-ketoglutarate is now changed into 2-hydroxyglutarate, which has properties that are leukemogenic through epigenetic phenomena. So when that mutation happens, we see increased levels of the 2-HG. These patients develop the leukemia. So because this is present only in the leukemia cells, targeting that is selective to the leukemia cells. And because it is pro-leukemogenic, if you block that, you can expect that you can kill the leukemia cells in a somewhat selective way, and we would expect with that much less toxicity. That was the rationale. FT2102 is an IDH1 inhibitor. And this is a study that's been a very comprehensive program, actually. The phase 1 study was a single agent drug trying to find the proper dose of this agent, and we did that. And then we have expanded the cohort of patients treated with this drug. Obviously, this is selective for IDH1, so only patients with IDH1 mutations are eligible. But what we have seen is that the drug has been very effective. We have seen a high response rate in this patient population, somewhere in the range of about 40% or maybe a little bit higher than that. It does that with very good efficacy. We have seen the differentiation syndrome that we know happens in this population. We've learned how to manage that, so you recognize it early, you manage with some corticosteroids, sometimes suspension of the dose. Some patients develop high white cell counts. You manage that with hydroxyurea, etc. But with that, patients are able to tolerate the treatment and obtain responses. There are durable responses, and this is an oral agent, so it has been able to be to do that with an ambulatory treatment. You don't have to have the patients in the hospital. So it's been a very pleasant addition. Of course, it's still an ongoing study. The drug is still under investigation, but the results have been very, very favorable. The program is expanding now. We're looking at combinations with azacitidine. the use in patients who have been exposed to other inhibitors, and other areas where it could also be of great value. Well, there are many different drugs that are emerging that are very promising in AML. We have these targeted drugs. We have monoclonal antibodies. I think that's an area of great interest. Both what we call the antibody-drug conjugates, so these are antibodies that have attached a toxin that specifically are trying to bring it to the leukemic cells. And then we have the bispecific antibodies that recognize the leukemia cells and the T cells trying to do an immune killing. These are very promising agents in this field. There are other agents that are directed at MCL1, for example, a very promising target. We're again interested in RAS mutations as a mechanism of resistance, so MEK inhibitors will make a comeback. Many of these drugs that are very promising, I think.